Okay, so we are going to pick up where we left off here on atrial fibrillation. I might repeat a few things just because I want to make sure that you didn't miss anything at the end of the previous presentation. So atrial fibrillation, it is irregularly irregular, which the QRSs will never march out in a fib. Also in a fib, we are talking about, again, remember the P wave, because that represents the atrium. And as in ventricle fibrillation, the ventricles just sit there and they just quiver. In atrial fibrillation, the atrium, they just sit there and they just quiver. So there is no defined P wave. It is just those fibrillatory waves, and it can be coarse or it can be fine. The only difference is coarse is that it comes off farther off of the baseline, and fine, it stays more closely to the baseline. So the wave is just chaotic. So as you can see here, there's just fibrillatory waves right here that it's kind of pointing out. And in normal sinus rhythm, this is just a P wave here. So this is what a fib looks like. It is irregular. The rate, it just kind of depends. It is, varying. And then your P wave, it's a fibrillatory wave, and there is no PR interval because you cannot clearly define a P wave. And then your QRS is narrow because, again, we do not have a ventricle issue here. We have an atrial issue. So we have gone through atrial flutter. We have gone through atrial fib. Now we are going to start talking about the ventricular rhythms. And the first one that I want to talk about is just PVCs. And PVC stands for a preventricular contraction. So for whatever reason, your ventricle contracts early. Okay? So here you have your P wave, your QRS, and then your T wave. And if you count out this strip, you have 1, 2, 3, 4, 5, 6. So our heart rate is 60, which is normal. They march out normal here. So I'm going to say the rhythm is normal. You can measure out your PR interval, and just by glancing at it, it does not look like it goes over one of the big red boxes. And our QRS looks, narrow. However, we have these two beats here that are abnormal. It is a wide and bizarre QRS complex, and this is a PVC. PVCs are not necessarily a problem. You and I, as we are sitting here going through this lecture, we might throw a PVC here and there, and that is no big deal. We don't feel it. It's just normal. You might have one every now and then. Okay, but when we come over here, if you have 3 or more consecutive PVCs, okay, we are going to start looking at an issue here. Okay, so if I was looking at this, I would say I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So if I was going to call the doctor and tell him what is going on, I am going to call him and I am going to say that my patient had a 16 run of V-tach. When your PVCs come consistently, one after the other, then this kind of turns into V-tach. If our patient would not have returned back to a normal beat here, then, this would sustain, and this is V-tach, okay? And that is a big problem. So, again, a PVC here and there, like over here, is not a big deal. And so I would call this rhythm, normal sinus rhythm with PVCs. And this was actually an answer to one of your questions on the worksheet. It was number 8. So that's normal sinus with just, PVCs. But this is a run of PVCs. Okay, so that's what PVCs are. Now we're going to go and we are going to look at VTAC. Okay, and specifically here we have monomorphic VTAC, and mono means one, so they all look the same. Okay, they're uniform. Okay, all these QRS complex look the same, and that is monomorphic. And again, since we are talking about a ventricular rhythm, we are looking at the QRS complex. Okay. The rhythm can be regular, it might sometimes be irregular, but for the most part, it is normally regular. There is no atrial rate because we aren't talking about the atrium anymore. We are talking about the ventricle. There are no P waves present, therefore we cannot measure a PR interval. And our QRS complex, they are wide and bizarre. Okay, so they are greater than that 0.12 seconds. Okay. This is VTAC, specifically monomorphic because all the waves look the same. Okay, and then here we have polymorphic VTAC. So poly means many. So there are many different looks to these QRSs. Okay, so again, the rhythm is regular, sometimes could be irregular. There is no atrial rate. Your ventricle rate is increased. There are no P waves, and therefore we cannot measure a PR interval. And our QRS again is wide and bizarre. They all look different, so that is poly, which means many. And so we have polymorphic VTAC. I put this one in here. I just want you to see it so you can see the difference between monomorphic, polymorphic, and then the torsades de pointes. This is what that looks like. This was not on your worksheet. I just want you to be familiar. You may be familiar with it. This kind of goes, is related to magnesium. So a patient that has torsades de pointes, more than likely you are going to give them magnesium. And then I want to talk about ventricular rhythms as far as VFib. So this is VFib, okay? It is chaotic. Our ventricle is just sitting there and it is just quivering. That is all that's happening. That is all the movement that is going on in our heart. There is no P wave, okay? Because the atrium is not doing anything. We are down to the ventricle, okay? And at this time, the ventricle isn't even pumping effectively to get blood out to our body. We have no pulse. It is just sitting there and it is just quivering. And over here, it defines what fine versus coarse is. So the flat line is your baseline. So if it does not come off of the baseline very far, it is considered fine. But if it does come off the baseline more than, there's not a specific amount of, but you know, the farther it is away from the baseline, it would be considered coarse. So that is the difference between fine and coarse. And you did have coarse ventricular fibrillation on your EKG worksheet. So I hope this was a little helpful for you guys. And if you have any further questions, I would definitely be happy to talk to you about interpreting EKGs. This is, again, what I consider just the easy identifiable ones. And these will be the ones that will be represented, you know, if you were to have a test question on them. Next year, this conversation will continue, and Lynn does a more in-depth EKG or interpreting EKG lecture and assignments, and you go into more heart rhythms. However, for right now, these are the rhythms that I would like for you to familiarize yourself with. Again, I would definitely like for you to open up all resources related to EKGs. There is a nice handout that goes through each one of the rhythms that we talked about on this slide, and it talks about the different causes, the different signs and symptoms, and the different interventions that we as nurses might need to do for our patients that are experiencing one of these rhythms. And I do believe it helps kind of bring all this information together when you look at that worksheet and you look at these strips. I think it helps paint the bigger picture and kind of close the gap. So again, if you have any questions or concerns, don't hesitate to reach out and ask me about this. So thank you.